All right, I'll let you start off.
All right. Well, welcome everybody. I'm Evan Lose. I'm a pediatric endocrinologist here in Johnson City at Niswonger, and I've got Seth Brown here with me co-hosting. Thanks for joining us for the 8 a.m. echo session on pediatric DKA management. Again, thanks for calling in on the echo session. I'm going to have Seth do sort of a little bit of a round robin of introductions.
All right, guys. So good morning. I think most of you probably know me. Seth Brown, the Peds ED Medical Director at Niswonger Children's. Just a few names at the top. So good morning, Dr. Lewis. And I have Dr. Dennis Carr. There's Dr. Al-Khatib, Dr. Denham. Do we have anybody else on the line? Not sure. All right. Anyway, so long story short, I think it looks like most folks are muted. So this is going to be super informal. We're going to try to make this as quick and to the point and as usable as possible. But if you have a question or anything pops into mind, don't hesitate to unmute and give us a shout. Glad you're here. Appreciate you guys taking the time.
Great. Well, thank you very much. And I don't know if you want to queue up the slides that we've got. But again, this project actually started because our clinic opened up for pediatric endocrinology about 3.5 years ago. And obviously we started with 0 patients with diabetes that we were managing. And now 3.5 years in, we've got about 500 with type 1 diabetes. And so on any given day, a couple of them invariably end up in an emergency room needing care either for diabetes or for some other reason. Sometimes that reason is DKA. And as the hospital system has gotten bigger and broader and we're all have some relationship with Ballad in some way, this is an effort to provide some unification to our DKA management in our pediatric patients, recognizing that pediatric DKA management is different than adult DKA management. And also just to make everybody aware of your resources, that you have peds endocrinologists that you can call if you need help. And you've got peds EDs in the area if you need to transfer somebody to admit them to a pediatric hospital. So again, we're looking for the slides. We'll get those up as soon as we can. Great. I think we've got those up for you. So Dr. Ford is my colleague, and he actually gave a similar presentation just a few weeks ago on the same topic. And we are rolling this out in 2 parts. He gave it on a Thursday, kind of midday, and I'm doing the Wednesday morning session to try to catch anybody who prefers this time. We're also, just so you know, it's no pressure, but we are studying the impact of rolling out an educational curriculum for our regional ED providers, just to kind of look and see, does this outreach have an impact on how we manage pediatric DKA in our area? So I have no financial interest or arrangements to disclose, whether that's a good or a bad thing. My objectives are to share and discuss this pediatric DKA pathway that has been circulated around the community. And I've got it in the presentation. We'll be talking a little bit about it, and it's been in use at the Niswonger ED. I actually developed the first generation of this protocol about 5 years ago during fellowship in Oregon, and then brought it out here when I came out here. And another objective is to identify those differences between pediatric and adult DKA management and highlight some clinical pearls as well. This is the protocol. We will break it down a little bit later, but it's color-coded. You should have laminated copies that are available in your EDs now. A little bit of background on type 1 diabetes. So it's only about 5 or 10% of all diabetes. So most of the diabetes that you see in the ER is going to be type 2 diabetes, mostly older folks. But in kids, actually in our area, if you're a child with diabetes, 90% of those children actually have type 1. It's about 1 in 400 prevalence for all kids. And peak incidence, really is all of childhood, age 5 to 15, but can be any age. So I've had 6-month-olds that are diagnosed with type 1. I've had toddlers that are told you're too young to get type 1. This couldn't possibly be diabetes. And I've heard of 60 and 70-year-olds diagnosed with type 1 diabetes as well. So it can be any age, but peak is right in the middle of childhood. It's autoimmune destruction of your insulin-producing beta cells in your pancreas. You've got a higher risk of other autoimmune disorders such as celiac and thyroid disease. There is a genetic risk as well. So if you've got a sibling with type 1, you've got about a 5% chance of having type 1. It's about a 6 to 8% chance if either of your parents do. And even if you're an identical twin, same DNA, about 50% chance that your identical twin is going to have type 1. So there are strong genetic components, but if it was all genetics, then your identical twin would be 100%. So we know that there's other random or environmental factors that add up to who gets type 1. However, when you meet a kid who's got type 1 and you're diagnosing it there in the ED, about 85% of the time, there's nobody in the family with type 1 diabetes. And they're saying, I've never heard of this. I thought only old people got diabetes. And so you may be the first person who's telling them about what type 1 diabetes is. Highest incidence is in Caucasians, but it can be in all ethnicities. We do have some type 2 diabetes, especially it follows with obesity. Again, we've got about 50 to 75 type 2 diabetes in our clinic. They do also go to the ER sometimes. Their management can be the same or slightly different. So this protocol is built for type 1, but may be applicable for type 2. If you've got a kid with type 2 diabetes who comes in DKA, this may be a time where you don't quite follow this protocol, but feel free to reach out to us. That's what we're here for. Type 2 diabetes in children, again, is a little bit different than in adults. You tend to have more rapid progression of beta cell loss and more rapid development of complications in kids compared to adults. And we've got plenty of kids with type 2 who actually present in DKA. And I've had plenty of kids also told, no, you're in DKA, this has to be type 1. Well, no, it turns out you can get your pancreas to kind of shut off even in type 2 and be insulinopenic and present with DKA, just like in type 1. They can present with a little bit of a mixed DKA and hyperglycemic hyperosmolar state, and that's where the fluid management and insulin management can be a little bit different than the protocol we're going to present, but just wanted to highlight those differences. Type 2 is pretty rare before age 10. I've seen it maybe a couple of times, but it is so obvious. That's the 8-year-old that weighs 280 pounds. But we've got a ton of 15-year-olds who weigh 250 pounds, and they come in and you're really not quite sure if it's type 1 or type 2. So just be aware of that as well. And I think that type 2 diabetes, like type 1 diabetes in kids, really does need to be managed long-term by a pediatric endocrinologist. I have had several kids who are even late teenagers and are told, oh, follow up with your primary care doc in a couple weeks. And they go home from an ER with a new diagnosis of type 2. I would prefer to be looped in on that so that we can be helping with the management from day one. So again, we're going to drop back here and focus mostly on type 1, and Seth is going to take us through a clinical case of DKA that's going to be obvious type 1 diabetes.
All right, guys, so our patient here is a 13-year-old previously healthy Caucasian girl who comes to the ED with a pretty typical history of 1 week of polyuria, polydipsia. She's vomited for a couple of days, and over the past 24 hours has become more somnolent. Parents initially didn't really think about it. It was the summertime, but now that they realize it, yeah, her clothes aren't fitting as well as they used to. So she's had a roughly 10-pound weight loss over the last month. There is a family history that is positive for autoimmune thyroid disease. You get some labs back, and on the venous gas, pH is 6.95, bicarb of 3.5, sodium is low at 128. Potassium, chloride are okay, but bicarb's less than 5. The UN is high at 50, creat is 2.5, glucose is elevated at 895, mag is 1.6, phos 4.5, large urine ketones, and you're able to get an A1C and it's greater than 13%. So on her physical exam, her BMI is greater than the 95th percentile. She has a pressure of 98/44, respiratory rate of 36, SAT of 99%, and she is dry. She's got dry mucous membranes, cool hands and feet, deep rapid respirations, and a delayed cap refill of about 3 seconds. And here's the kicker: she's got an altered mental status as well. So, so guys, any thoughts on the presentation of the case thus far? Sick, not sick? What are your, just throw out a few things that are coming to your mind in terms of this slide on the presentation.
Definitely, clearly quite sick. On the adult side, first thought is aggressive fluid hydration.
There you go. Okay, thank you. Any other thoughts?
Great. So the goals of DKA therapy in kids, and some of this is shared with adults, is correcting dehydration actually slowly over about 48 hours, correcting the acidosis and reversing ketosis, getting glucose back to normal, although it doesn't have to be normal right away, identifying and treating any precipitating events that may have led to the presentation of DKA, and then trying to avoid complications of therapy. And that's where this pathway is really focused on some of the differences between pediatric and adult care, and how if you follow adult care, you may increase the risk of some complications that are seen more in kids. So again, here's the pathway, and I've tried to break down the lots of words into some of the just sort of basic concepts. And so really in the first 60 minutes, you're all going to be getting labs. And once you've got an IV access established, then essentially everybody's going to get a normal saline bolus. The details of this bolus we're going to go into. After that, you're going to proceed to insulin drip if you confirm that this person does have DKA. Obviously, if they just have high blood sugar and they're not ketotic and they don't have acidosis, they don't need to be on a drip. But then what do you do with ongoing fluids after that, anticipating that this is a kid in DKA who's going to need ongoing care and probably admission? What do you do as far as arranging transfer? When do you need to repeat labs, adjusting fluids, and monitoring for complications like cerebral edema? And then the don'ts, and this is where we've highlighted some of the things that can increase the risk for cerebral edema. Bolus insulin, excess fluid boluses, the use of bicarb, which I've got an asterisk there because we're going to talk a little bit more about that. And then don't miss cerebral edema. It probably happens more often than we realize. Maybe should be treating it more often than we do. And some of the guidelines from the international community actually recommend maybe more aggressive treatment for cerebral edema than traditionally we've done in the United States. So we'll talk a little bit about each of these. This shouldn't be any new information for anybody, but warning signs of new onset diabetes. Sometimes it's just part of your history, and this can really get you there very quickly. Polyuria, polydipsia, polyphagia, unusual weight loss, fatigue, irritability. And I'll share one story of a kid who came in who had essentially an acute abdomen, and everybody ended up being focused on appendicitis, had a white count of 60,000, and everybody thought they were on the right path. And then as they were in the OR taking this kid's appendix out, somebody went back and checked the initial labs and saw a glucose of 700. It turned out, no, this kid actually had diabetes, DKA, and the abdomen was actually just related to abdominal pain from ketosis. Now they didn't have an appendix, so I guess that was nice. But again, it's just nice as you're working up these kids very quickly to take 2 seconds and find out if it's diabetes. The clinical definition of DKA, if you have to define it, it's going to be a glucose of over 250, you need a significant amount of ketones, and you need metabolic acidosis. Now there's some overlap here. You could have kids who come in with just a really terrible gastroenteritis, they've got a stress hyperglycemia, they've been vomiting, and so they could have ketones, and maybe their pH is 729. So you could have kids that actually meet the definition of DKA who actually don't have diabetes. Or you could have somebody with known diabetes who took a big slug of insulin an hour before they came into the ED, and their glucose is actually 150. But it's because they've already started to treat their DKA at home. And so maybe they don't qualify for the actual clinical definition, but you know that they're in DKA. So this is the official definition, but you have to use your clinical brain too. So back to this fluid bolus. And so the protocol, again, the first thing that you're doing after you're getting IV access in is giving a normal saline bolus. And this is the difference between kids and adults, is that kids have a tough time tolerating a big, massive fluid bolus. Adults seem to be able, you can give them 2 liters, you can give them 3 liters, you can give them 4 liters, and they seem to do okay. But when they've looked at big case series of cerebral edema with death, one of the common denominators tends to be really over-aggressive fluid boluses. Again, a lot of it is retrospective data, so it's hard to say, were these the kids who were super sick and so they just got the most aggressive management, or did the extra fluid actually contribute to their poor neurologic outcome in the end? The thought is that it's probably more of the actual fluid bolus that's actually doing it, but nobody wants to sign up for that randomized clinical trial where you're saying, well, there's a chance that we're going to give you cerebral edema, and so we're just going to go ahead and give you a bunch of fluid. So around the world and around the country, everybody over about the last 5 or 10 years has been moving to a modest fluid bolus, more in the neighborhood of 10 to 20 mils per kilo of normal saline. It's certainly not going to replace their fluid deficit, but it's going to get them moving in the right direction, reestablish some perfusion to the kidneys so the kidneys can start peeing out some of that glucose. And so we'll typically start with 10 mils per kilo over about 30 minutes, and then assess the need for a second 10 mil per kilo bolus. But if you take a kid who's 30 or 40 kilos, give them 2 liters, that's probably going to be too much. Again, lots of fluids that are associated with osmotic shifts, cerebral edema, death in kids. We try to minimize those. Hemodynamically unstable patients, everything is on the table. So if you got a kid with a really soft blood pressure, if you're not perfusing, you don't have a kid. So you need to make sure that, if you've got no blood pressure, go ahead and give them whatever fluid you need to make sure that they're hemodynamically stable. But if you've got a kid with a decent blood pressure, you can go ahead and be a little bit, more mild with fluid boluses, starting just with 10 per kilo. Any sort of responses? I mean, the reason I'm stressing this is, I don't know, maybe a third of the time that I'm on the receiving end, I see kids who end up getting probably more fluid than they need. Most of the time, I don't see bad neurologic outcomes, but that's part of the reason for this presentation. So feel free to give me feedback if you're like, no, that's wrong. Please let me know. All right, cool. So after fluid has gone in, then insulin. And so recommendations are actually at least 30 to 60 minutes actually after you get that fluid bolus started, then go ahead and give insulin. So you don't need to give fluid and insulin. Give the fluid first, give it time to go in. Often you're actually going to see glucoses come down a couple hundred points just with an initial fluid bolus, just by diluting out their inner ocean. And you'll see a glucose at 800 come down to 500 or 600. And it used to be that, an insulin bolus was part of initial management. You said, this kid's missing insulin, let's give him some insulin. And then again, retrospective data said, it was the kids who got insulin boluses who ended up with poor neurologic outcomes. So again, was that because they were sicker, so they were getting more interventions up front, or was the insulin bolus actually contributing? I don't think that's 100% clear, but over about the last 10, maybe 15 years, the insulin bolus has gone out of vogue. So if you trained more than 10 or 15 years ago, or even if this has been part of your standard practice up until this point, would encourage you to not give the insulin bolus. Adults, again, they seem to tolerate insulin boluses just fine. So if your usual management is give them a couple liters of normal saline and 10 units of regular insulin, think twice when you're talking about kids. And then another word of caution about using some other protocoled DKA management, something like Glucomander, if you use any of those. Those are built mostly for type 2, mostly for adults. They don't tend to work very well for kids with type 1. And so caution in using sort of other protocols. Insulin drip, we typically start at 0.05 to 0.1 units per kilo per hour. I tend to start on the 0.05 side and work up if the acidosis is kind of slow to correct. Other people start at 0.1 and come down. Some pick 0.05 versus 0.1 depending on how sick the kid is. When they've actually done randomized controlled trials looking at the difference between 0.05 and 0.1, they actually have not shown any difference in outcomes, even time to resolution of acidosis, length of stay. So I don't really have any solid guidance on which one you have to choose, but our protocol just says 0.05 to 0.1 units per kilo per hour. And then if your glucose is dropping, just add more dextrose. Please don't turn off the insulin drip. That's maybe a sure way to have the body continue to be ketogenic, is to stop giving insulin. So if you've got a glucose that's just plummeting, go ahead and just ramp up the dextrose, and you don't have to turn the insulin drip down or off. This is all detailed in the protocol as well. If you have the ability to do what we call the 2-bag method, then we'll talk about it a little bit here. But I don't know, Seth, if you want to say anything about the 2-bag method and whether that's, if everybody should be doing this or whether this is like DKA 401 level stuff.
Sure. So I think obviously this is going to depend on your location. Our region has everything from very large tertiary facilities to community EDs to critical access hospitals. And in the critical access hospitals, I think this would probably be a big reach.
Yep.
Just from the perspective of manpower.
Mm-hmm.
Most of the critical access hospitals don't have pharmacy backup in-house.
Mm-hmm.
So trying to get a specialized bag like this would be a little more difficult. Now, on a perfect day, if you had a pharmacist just happen to stroll through the ED and they saw the DKA patient and you said, hey, can you mix these bags for me and help me with the formulation, then great, absolutely. But I would say at the end of the day, it boils down to your setting.
Great, thanks, Seth, for that. And I tried to, the second to the bottom bullet point sort of detail this as, if all this other fluid stuff is not available, just go ahead and put them on normal saline and run them at 1.5 mg. Everybody should have that. And then hopefully the ability to add some dextrose if your glucose is dropping under 300 and add some potassium if your potassium is starting to drop. But if you want to get fancy, it's on the protocol. And the 2-bag method is essentially 2 identical bags, one with D10 and one with D0 in it. And you can either do it with normal saline or if you're fancy, then sodium acetate with some potassium in there. Potassium chloride, potassium phosphate, and then titrating the ratio of those 2 fluid bags to try to achieve glucoses that are under 300, but there's no point in trying to get them down to 100. If they're a kid with new onset diabetes, they've probably been running 4, 5, 6, 800 for a week. So there's no reason to get them to 100 right away. Just get them down between 2 and 300 and park them there. And so they may need D5 to do that. They may need D7.5, D10. And you can adjust your fluid rate a little bit if you need to as well. So if you're maxed out D10, 1.5 maintenance, and you're going, oh, his blood sugar is still dropping, just go ahead and run it at 2 times maintenance. That's okay. But so this is, it looks detailed, but really your goal is you're beginning your rehydration faster than maintenance, and you're adding dextrose when your blood sugar drops, and you're providing some of the electrolytes that the body's missing out on, potassium and phosphate. In transport, again, depends on where you're coming from and what the abilities of your transport team are. But I think it helps to at least have a conversation about what IV fluids are we running? Are we running an insulin drip during the transport? And what's our lab frequency? You can talk about that with the PICU team, the receiving team, because they would love to know what they're coming in on. And we've had kids who we thought were on insulin drips who came in on no insulin. We've had kids come in on too much insulin. We've had kids not get labs drawn for 6 or 8 hours from the time that they initially presented to the ED, and then they eventually end up in the PICU. So all of this is a way to be able to start essentially critical care management starting the moment that they show up in an ED or critical access hospital. Electrolytes, again, this is what's in the protocol. Sometimes you you don't have to like set your watch to it, but just know that if this kid is sitting in your ED for more than a couple hours, you're probably going to want some repeat labs. So typically we get VBGs every couple hours, a BMP every 4, and then you can get a mag and phos. I don't typically say you have to keep repeating those if the first ones are pretty normal, but we'll do that until the acidosis is resolved. That's going to be probably in the PICU. Usually if they're better before they're leaving the ED, maybe they don't need to go to the PICU. And then potassium, sometimes these kids show up total body potassium depleted, but their intravascular potassium may be 5, 5.5, 6, 6.5. And you're worried, why am I giving potassium to this kid with a potassium of 6? That makes no sense. And that's true, it really doesn't. So waiting until potassium is under 5 and you've proven that these kidneys are working and they're voiding, then you can add some potassium to the fluids. If they've got no urine output, even though you've given them that initial fluid bolus and their potassium is high and their creatinine is 2.5, you gotta be a little cautious about dumping potassium into somebody whose kidneys are maybe not ready to filter them. And then we ask to keep them NPO and try to keep close track of their ins and outs, just so that we can make sure that we're calculating all that in with their fluid rehydration over the next day or 2. All right, now on to cerebral edema. Again, as I mentioned before, this probably happens more often than we realize. And some of the percentages here are tough to know. There's data out there that says if you've got cerebral edema, then you've got 20% chance of mortality. But there's also data out there that says 50% of people with DKA probably have some cerebral edema, whether we know it or not. So I think it's the really obvious cerebral edema. Those are the kids who are at the highest risk for actual bad neurologic outcomes. But the international community for about the last 10 years has said, why do we wait for somebody to show really severe signs? If you've got any suspicion that this kid is a little bit altered, they're saying my head hurts, you can go ahead and start treating them presumptively for cerebral edema. You're going to have higher risk for cerebral edema in kids who present more severely, either with lower pH, higher BUN, lower PCO2, higher potassium, and that's all evidence-based. If they've got altered mental status, if they're a new diagnosis, or especially your young kids. And then that bottom line there, retrospective data showing insulin boluses, excessive fluid boluses, and potentially bicarb use as well is associated with higher risk of cerebral edema.
Let me ask you a question. What did you say that the youngest child, the youngest age was that you've seen with DKA?
Yeah, so I mean, I've seen one kid who was 6 months old, and I was always taught, that new diagnosis under a year, you should really worry that this is more some congenital pancreatic problem with, insulin release deficits. And nope, this kid turned out to have autoimmune type 1 diabetes, positive GAD antibodies, and totally ended up having type 1. So 6 months is definitely uncommon, very uncommon, but I actually have plenty of kids who are kind of in the 12 to 18 month range. I know, Seth, I know you've seen them. I've taken care of probably 10 in the last 2 years. And so they're going to come through your EDs.
And the reason I bring that up is being able to differentiate an altered mental status in a 9-month-old may be even more difficult, especially if you don't see kids on a regular basis.
Right.
So if you think about, you've got 2 beings right there. You've got altered mental status and a young kid that may mask cerebral edema.
Yeah, absolutely. Absolutely. It's really, really hard. And invariably, these kids come in at, 2 o'clock in the morning, and probably the parents have some cerebral edema at the same time. So, maybe everybody needs a little bit of so here's your signs of cerebral edema: altered mental status, severe headache, seizure, Cushing's triad. And again, Cushing's triad is so, it'll fool you because you're going, hey, their heart rate was 160 and now it's 100. Oh, that's a good thing. Maybe their hydration's getting better. Oh, their blood pressure was kind of soft and now it's come up. Oh, they were Kussmauling and now their respiratory rate's down to 12. Those could all be signs that your brain is really trying to tell you that it's not happy. if your O2 sat's dropping, if you've got pupillary changes, obviously you're deep in this. And then sort of the overall gestalt, but you're clinically worsening despite improving lab values. Cerebral edema can happen before they show up in the ED, while they're in the ED, or after the ED. Actually, within the first 24 hours after we start treatment is actually maybe the most common time to get cerebral edema. And obviously, we don't have any control over if they have cerebral edema when they show up. So we're focusing on what can we do from the moment they get there to decrease the risk for cerebral edema going forward. So treatment, if you recognize cerebral edema, actually reducing IV fluids. A lot of this is aimed at decreasing the rate of change in the osmoles. So, my, small brain, I think about cerebral edema in probably the most simple physiologic way, just that if you've got serum osmoles of 400, well, then your neuron osmoles are 400. And if you change your serum osmoles down to 300, fluid's going to go into your neurons. And so anything that you're doing to bring those serum osmoles down, we try to do that gently. And so, again, a lot of fluid, a lot of insulin, and potentially bicarb could do this a little bit as well. Can drop your serum osmoles faster and cause increased cerebral edema. So raising the head of the bed, intubate if you have to protect the airway, but try to avoid any hyperventilation. There's actually some good data on hyperventilation causing decreased neurologic outcomes. And then what we should probably be jumping to a little bit faster than we historically have is pharmacologic management of cerebral edema. The protocol talks about either mannitol or hypertonic saline. There's actually not a preference one for the other. There's a few studies out there that say one's better than the other, and there's about equal number on each side. I typically have reached for mannitol first. I don't have a reason why, other than I can remember the dosing a little bit easier. But if you like 3%, that's totally fine as well. And the harm in giving mannitol and hypertonic, I think, is minimal compared to the potential huge benefit for someone who was going to have cerebral edema and you've averted it.
Let me ask you, if you don't mind, go back real quickly. So how many of if it's a clean, straightforward DKA patient, how many of those have you seen require intubation?
I've probably been at the bedside when we've extubated maybe one kid in the last 2.5 years since I've been here. So it's really pretty rare.
Right.
If you're thinking about intubating a kid with DKA, one, they are very, very sick. And also you have to be pretty cautious too. I mean, I actually use this as a teaching case for the med students. And I say, if you've got a kid with a pH of 6.8 and you're going to go ahead and paralyze them to get an ET tube in, what happens to their CO2 when you paralyze them? They did have Kussmaul respirations, and now you just pause their respirations. Well, their CO2 goes up and their pH goes from 6.8 to 6.79, 6.78. And at what point does your cardiac myocyte say, forget about it, I'm going to go into VFib? I don't know. I don't know what that number is, and I don't want to find out. So I've had folks, I used to be in a place where we were receiving kids from 5 hours away, and we would say, please don't intubate this kid, just bag them, and they're actually going to improve.
Well, my point is a very, very, very few of these children actually require intubation. In 10 years, I honestly can say I've maybe seen 2 that have been intubated in the emergency department. So it's very much a minority of patients that need to be intubated. The other thing to remember is we may have a well-intentioned respiratory therapist who may not be used to normal respiratory rates in kids. And if they're at a critical access hospital, they're used to putting adult patients on a rate of 12 or 14. And it may be worth a discussion to inch with the intensivist, with the PZD physician, inch that rate up a little bit, because again, if you look at the Kussmaul pattern that brought them in, the body's smart, right? The body's trying to compensate for the metabolic acidosis, and there can be a lot of harm that comes from adding on a respiratory acidosis to either hypoventilation from a low rate perspective. Maybe it looks like an easy intubation, but when you get in, it takes 3 or 4 times to pass a tube. in 3 or 4 minutes to get that done. I mean, hopefully that's not going to happen, but it's all things we have to at least anticipate.
Yeah, these kids, even though they come in super sick, their bodies are still reasonably smart. And so they're maximizing their minute ventilation, that, tidal volume and respiratory rate. There's almost no way you're going to be able to ventilate these kids better than a Kussmaul respiration actually. So they're clearing off CO2 really, really effectively. Almost anything you do mechanically is going to slow that down. Cerebral edema imaging. This is a question that I get actually somewhat regularly. And the emphasis now is actually to say cerebral edema is really a clinical diagnosis. And where do you want this kid who you feel is so sick that they need to be in the CT scanner because of cerebral edema? Well, probably not in the CT scanner. You don't want to be intubating and running, getting that call that says, doctor to the CT scanner emergently. So imaging is actually normal 40% of the time in kids who ultimately go on to have like pathologic cerebral edema and neurologic outcomes. So a CT scan is actually not that reassuring, and you shouldn't be making the diagnosis of cerebral edema on a CT scan. If you think this is cerebral edema, just go ahead and treat it. If anything, it's going to delay the appropriate treatment. And then a question about bicarb. Again, this actually used to be part of protocols. So if you trained in a place with protocols from 10 or 15 years ago, it may have included bicarb. Adults get bicarb with some regularity. Turns out retrospectively, bicarb and kids don't mix super well. It's just associated with more cerebral edema and death. There is probably a place for bicarb, and this is where you get to use your clinical brain, please, and tell me, I know that the protocol says try not to use it, but I went ahead and used it, and this is why. And typically it's going to be those super sick kids, pH under 7, and cardiac instability. And so the combination of both of those, international guidelines actually say, yes, go ahead and use bicarb. But if you've got an average DKA kid who's coming in with a pH of 7.1 or 7.2, certainly bicarb should not be part of your typical management. That's really sort of running through the details of the protocol. I did want to get any feedback that you guys have as far as if you've seen the protocol, if it's up in your EDs, or if you need a copy, we can make sure we can get it out to you.
Or if you have any questions of previous cases or any other thoughts that come to mind at all after hearing the discussion. This is super informal, so just throw out any thoughts you may have. And if it's too early and you need more coffee, that's okay too. Because I haven't had mine yet. I'm already thinking about getting a cup.
What we're hoping this will do is unify a little bit of our pediatric DKA management across a bunch of different hospitals in the area. And I end up being very much on the late receiving end. Usually it's the PICU telling me about a kid who's already there. They've talked with you. You're the ones who are there. So I really appreciate you taking care of our 500 kids with known type 1, and then the 50 who are going to be diagnosed in 2019. We're averaging about 1 a week. So for the 50 new onsets that are going to come through probably your EDs, thank you in advance for your management, your treatment of them.
And remember too that you can get in touch with ED attending, PGD attending, the PICU attending, as well as the PEDS endocrinology attending on call anytime via MD Connect. So don't hesitate at all to, if something's not quite adding up with the patient, if you have any question about any management, please don't hesitate at all to reach out. All right. Any other thoughts? Any last questions?
Seth, Evans, thank you guys. It's Matt Dye from over at JMH.
Hey, man.
We have the protocol. It's up in the ED. I think we got 4 or 5 copies of it, and so we will. And we got a couple people who showed up. Thanks everybody from my department who came to the meeting.
Great. Thank you
so much.
Appreciate that. Good to hear you. And anything we can help you guys with in the JMH area, please don't hesitate. All right, everyone. I think these are going to be archived. So if you do have colleagues that weren't able to make either session, but still would like to brush up on the DKA management, they can navigate to the ETSU Echo website and definitely access these anytime. So thanks so much, guys. Have a great rest of your day.
Take care, everybody.